Hello everyone and welcome to the NKT study group on jaw versus suprahyoid. What we want to do is help you not only with your palpation skills, help to determine the most dysfunctional structures associated with jaw and suprahyoid, but also give you a little bit of palpation guide and also a couple of functional tests that are duly specials to help you get to the primary as close as possible. So just to review the major muscles of the jaw, we have lateral pterygoid, medial pterygoid. These muscles are going to deviate the jaw to the opposite side. Bilaterally, they contract for protrusion, and they can also help to elevate and depress the jaw, with lateral pterygoid being a depressor and the medial pterygoid being an elevator. We also have masseters, which help to unilaterally, ipsilaterally deviate, and bilaterally help to elevate the jaw. They can slightly participate in protrusion and retrusion, but not much. And then of course temporalis, we know its primary jaw muscle activity is to elevate and to retrude. It doesn't participate much in ipsilateral deviation, but it can sort of help masseter in a way. So barring aside that you know that that's true, and barring aside that you've done jaw-to-jaw relationships with your level 3 skills, you might find that the person is still deviating the jaw, and you can't determine whether it's jaw to suprahyoid or even suprahyoid to suprahyoid or suprahyoid to infrahyoid musculature. So when you're trying to differentiate jaw from suprahyoid, we have a couple of case studies here with Kieran and Stu to show you, wow, this person has a jaw deviation. Is it jaw to suprahyoid, or is it jaw, not even really a primary involvement, and we can get their deviation to really improve by working on the supra and infrahyoid relationships at the hyoid. So here we go. A couple of palpation points. I know you guys probably know the palpation points for the pterygoids, but in case you don't, let me just go over those. Medial pterygoid, if you are a non-oral therapist where you can't glove up and go inside, a great place to do a passive TL is right underneath the angle of the mandible. So just take a second and feel that. For the lateral pterygoid, it's going to be very hard for you to feel on the outside, so I usually use a Q-tip, or if the person is so inclined, the finger, a gloved finger, to go behind the back maxillary molar and then push directly up towards the ear. I have a video that I'll put at the end of the write-up for this if you want to go over palpations for the lateral pterygoid intraorally and medial pterygoid intraorally. If you're not intraoral, you can always do active therapy localization, which is a little bit of an opening of the mouth and jaw deviation to the opposite side for the lateral pterygoid, and closed mouth deviation to one side for medial pterygoid. And it's always going to deviate to the opposite side. For master, I know you guys know the palpations are super easy to feel that. It's very superficial, from zygomatic arch, zygoma, over to the superficial surface of the external portion of the ramus of the mandible. Just make sure when you're down here by the angle, you're not underneath the angle of the mandible, because that's medial pterygoid. Masseter on the outside of the jaw, inside you're going into more medial pterygoid. So now the supra and infrahyoid palpations. We're going to be feeling these for tightness, because in NKT tightness means dysfunction. So what you want to look for is some of these major landmarks for your supra and infrahyoid palpations. So for suprahyoid, go over to the digastric notch or digastric fossa, which is just underneath the chin. So just hook your fingers underneath and palpate for tenderness. This is anterior belia digastric, which is a jaw muscle and an indirect hyoid muscle. In the midline is the mylohyoid, and just lateral to the anterior bellies of digastric are going to be mylohyoid as well. This is the diaphragm of the mouth, a very common dysfunctional muscle to find in the suprahyoid region. I find it so much that I almost accidentally say mylohyoid when I mean suprahyoid. It's very, very common to find dysfunction here. It is a functional floor of the mouth muscle. Now, mylohyoid actually attaches to jaw via the mylohyoid groove. So another place I love to palpate as a duly special is to hook your fingers underneath the proximal portion of the body of the mandible, hook underneath, like so, and start to palpate the mylohyoid line. The mylohyoid line is the attachment onto the jaw for the mylohyoid muscle. Geniohyoid is a little tougher to feel, but it has a little bit more tongue involvement because of its co-contraction with genioglossus. So if you go right to the center where mylohyoid is, and you start to push up and then have them move the tongue up and down, you might feel some tension generate under one finger, and you might have some excessive tonicity and tightness. In that case, you would look at geniohyoid. And then, last but not least, stylohyoid and posterior digastric. If you come to the mastoid process and come medial to that, you'll feel a ridge called the digastric groove. Put your finger there and open the jaw wide, and you can feel a contraction at your fingers. And if that person's also tender and tight there, could be a dysfunctional posterior biliary digastric. For stylohyoid, you'll come right in front of the mastoid process, come directly anteriorly and inferiorly, and you feel a long stylus. That's the styloid process of the temporal bone. Palpate that for tenderness, and start to trace your way over. You'll start to feel the stylohyoid, which all of these muscles can either directly or indirectly move the hyoid up. That's important to remember because the initiation of swallowing is moving the hyoid up. These muscles, if they attach to the jaw, like mylohyoid, geniohyoid, anterior and posterior bellies of digastric, when the hyoid is fixed, they depress the jaw. So if you put 2 fingers in your mouth right now, that action is gravity and lateral pterygoid. You can feel that because the muscles underneath in the suprahyoid region are actually not very tense. But as you put 3 fingers in, now the jaw is forcibly opening, and that's suprahyoid function, not lateral pterygoid function. So if you put your 3 fingers in, and now you can feel the tension down here. So a very big way we can differentiate between jaw and suprahyoid is going to be 2 fingers versus 3 fingers. Right? If you have a very dysfunctional suprahyoid that tends towards facilitation and inhibition of the infrahyoids, you'll be able to put 4 fingers in. And these are the people that really have, hyperfacilitated suprahyoids. That's not always present. So, but you definitely would find a possibility of a lot of tension there. If the person can't put 3 fingers in, expect suprahyoid inhibition. Okay. Now, down lower, the infrahyoid muscles help to depress the hyoid. So during the last phase of swallowing, not the initiating phase, but the last phase, they bring the hyoid down. So let's palpate those. The first one is going to be sternohyoid, pretty easy palpation. To find the hyoid bone, you're going to go right towards the center of the mandible, trace your way straight backwards, and you'll find a big bony square. That's the body of the hyoid. Start to trace your way out laterally, and you can feel the hyoid bone. Now come back towards the body and start to feel straight down, very superficially. David always says when you're palpating these things, use the pressure on, as you would put on an eyeball, like an eyeball of your grandma, nice and light. And then you can hook yourself underneath the hyoid, and a lot of tension can be present here in the sternohyoid muscles. Just deep to that is the sternothyroid musculature. This will affect vocalization in a very big way. And then the omohyoid and thyrohyoid, you come over to this area and you're on the greater horn, so between the SCM and the body of the hyoid, and then you're going to feel very laterally for superior belly of omohyoid and a little bit more intermediate and deep for thyrohyoid. So these are great places to palpate for pure patch palpation for infrahyoid musculature. For the inferior belly of omohyoid, you're going to find the SCM. And at the midpoint of the SCM is the point of nerves. You stay superficial and come off of that point of nerves and go towards the suprascapular notch of the scapula. And then you start to raise the shoulder up, raise the shoulder down, or swallow. And you can feel the contraction of the inferior belly of omohyoid. The inferior belly of omohyoid will tend to cause certain clinical signs that we'll see, and you'll see that on Stu today, that the person might be missing external rotation of their humerus due to possible impingement via the omohyoid to the suprascapular nerve. And so they lose external rotation and initiation of abduction because the suprascapular nerve actually innervates supraspinatus and infraspinatus. So now to put you to it, I know you guys know how to assess the hyoid and you know how to assess the jaw, but it kind of helps to see a couple of case studies and some people that are dysfunctional. So I have 2 volunteers. Let's start with Stu. Where's Stu? Hi, Stu. Have a seat here. Okay, and you're going to look towards here. All right. So Stu, can you tell them a little bit about your dysfunction, why we are choosing hyoid and jaw for you?
I was an MMA fighter there for a while, and I've been in a lot of triangle chokes. I've been choked out a number of times. I've also had my jaw busted to the left in a triangle choke. It was actually on a little bit high. Instead of being on my neck, it was actually on my jaw, and the whole jaw went crunching and tearing and popping sideways.
Wow. So that shows us that we may have an involvement with the jaw or the suprahyoid or both, and they could be even a dysfunctional relationship together. So we got our work cut out for us, right? So you're gonna look straight ahead. Is your water, Stu?
Yep.
Okay, great. So I'm gonna put Stu through a couple of functional tests. So Stu, you're gonna look straight ahead. We're always gonna make sure the cranial axis is set, so neck long, chin tucked, okay? And we wanna make sure we look for persons that actually do a lot of cervical extension. A lot of times if they have jaw or hyoid problems, they'll do a lot of this capital extension stuff, particularly when there's jaw involvement. Okay, so Stu, if you can look straight ahead for us, we're first gonna just look at your jaw movement. So if you could just open the jaw and close. Something interesting happens when you watch Stu's jaw. Just go down about an inch, and you can see there's not a lot of deviation, but it increases as he starts to open the jaw. And just like he got pushed so long ago over to the left, you can see that his jaw deviates to the left. Okay, but it only happens when you force the jaw open, which increases my potential of a jaw to suprahyoid relationship that may happen. But for me, or sorry, decreases the tendency for jaw to suprahyoid. If the deviation of his jaw actually happened in the initial states, like the initial 1 inch, then I might include the jaw. But for Stu, it doesn't happen until he forces the jaw open. Go ahead and watch again. When he forces the jaw open, it gets a lot worse. So to me, that's like, okay, the jaw may be involved, but if there's a suprahyoid relationship with something, the jaw will tend to deviate after the jaw is forced open because the lateral pterygoid doesn't do that. So very interesting that we're already kind of pointing ourselves towards the hyoid. If you look at Stu closely, his Adam's apple or laryngeal prominence actually deviates over to the right. Okay, that can be important because that can mean that the right side stuff tends to pull his hyoid with the thyroid cartilage. Those two structures are separated by the membrane, so where the thyroid cartilage goes, the hyoid will tend to go. So when we palpate, we may actually see the hyoid won't move to the right, okay? When we palpate the hyoid just gently and come in, like you learned with David in level 3 Vimeos, we can just palpate and see if there's any restrictions. And I'm gonna be very gentle. Just put him in a good cervical axis. And he has a little bit of restriction pushing to the right. With hyoid corrections, we want to make sure we're very careful never to push into a direction of resistance. Less resistance to the left. As I palpate the upper parts, I can't move his tilt up on this right side. It looks like it's tilted down, which can mean either facilitation of the opposite side or inhibition of this side's suprahyoids. Okay, very good. If I have Stu do the test we talked about, we can actually say, okay, Stu, let's put 2 fingers in your mouth, which he doesn't have a whole lot of trouble doing. If people have a masseter, medial pterygoid, or temporalis dysfunction, they won't be able to put 2 fingers in their mouth. They won't be able to drop the jaw. Okay, and then put 3 fingers in. And that's really hard for him, but it should be relatively easy. So if you have a suprahyoid involvement, especially inhibition, the person won't be able to put 3 fingers in. Now, I'm not gonna make you do 4, because that would be super dysfunctional and usually suprahyoid facilitation, but he's not a good candidate for that. If you can't do 3, you can't do 4, okay? For the swallowing test, the hyoid is supposed to be moving up when you swallow and then down at the end of swallowing. So the initiation of swallowing, the suprahyoid muscles are going to fixate at the jaw and then allow an elevation to occur at the initiation phase of swallowing. The infrahyoid muscles are supposed to drag it back down. So if you have a functional hyoid, it'll move up at the initiation and back down at the decrease. So I'm going to actually feel that. And then, Stu, do you mind taking some water in? We want to reproduce the test the same each time, so keep the water in your mouth. Cranial axis is neck long, chin tucked, and go ahead and initiate swallowing. And I feel that Stu has a little bit of trouble moving this right side, okay? To see if the hyoid muscles are involved, I'm gonna have him put his tongue on the roof of his mouth this time to swallow. And that should make swallowing easier, right? But if it makes it harder, I know there's a suprahyoid involvement somewhere. So don't swallow yet, and go ahead and swallow. Sorry.
That's all right.
Okay?
That's all right.
So he can't really do it and then tries to do a cranial movement to create it to happen. So the very, very good sign of possible dysfunction on Stu for this one. Okay, great. If we palpate Stu, we find mylohyoid to be very high tone on the right side. Not so much anterior belly as a digastric. Open your jaw, Stu. Not so much posterior belly as a digastric. Not so much stylohyoid. Put your tongue on the roof. Not so much geniohyoid. Okay. And I come over to his hyoid here. SCM medial to that. Superior belly hyoid. A little bit tonus. Sternohyoid a little bit on this right side. Tendering here, Stu.
Yeah.
How about the left side?
No.
Not as much? Okay. So for Stu, a lot of right side tonicity, tightness, that means dysfunction to us. So there's a really good possibility that there's a right side dysfunction here. The superior belly was high tone to fill the inferior belly. I'm going to come lateral to his SCM at the midpoint. Put my fingers across. Good. And go ahead and swallow for me. And I feel like a normal contraction here, but I don't really feel a ton of movement happening on this side. Okay? Since the superior belly hyoid and inferior belly hyoid are linked to the suprascapular nerve, I can actually put Stu into a basic functional test. Stu, can you scoot back a bit? Awesome. And if I put him into a test, I'm looking straight ahead. Good. And I just want you to do a supraspinatus. Good. And relax your wrist. Good. So you're going to just initiate abduction, hold here, and I'm going to try to push again. So we'll relax. Okay. Take a deep breath in, all the way out, and then don't you push. Okay. Stu is weak in the clear there. And for infraspinatus, can you hold here? Good. Deep breath in, all the way out, don't you push. Okay. And if I put your hand on those high tone hyoid area, good. And deep breath in, elbow straight, all the way out, don't let me push. Now I can't push him in. And for infraspinatus, deep breath in, all the way out, don't let me push. I can't push him in. So if someone has a possibility of affecting the omohyoid and they therapy localize the hyoid area, it should turn on muscles that are commonly inhibited by omohyoid dysfunction, which is global patterns like infraspinatus and the supraspinatus. For Stu, I wouldn't go releasing this in relationship to those muscles. This is a global pattern. This is probably trickle-down effect for something that's pretty local. So we could check that at the end and just see if it improves in the clear, which it very well may do. Okay. And then what we'll do in a second is we'll do perturbation to see which axis we would start with. Because, and I know you guys already know your hyoid corrections, and there's a separate hyoid study group, but you wanted to start in the axis where they have the most dysfunction, x-axis, y-axis, z-axis, so you would use your perturbation testing, right? So we'll put you to the side for a second. You're not a great candidate for the jaw, despite your jaw deviation, right? He's a better candidate for looking at relationships at the levels here. But we can go for pair TL-DOD here in a second and show you that breakout. Can we use you next? All right, Kieran. Can you tell them a little bit about your jaw dysfunction?
Yep.
Okay.
No direct blows to the jaw or any choking related stuff, but I've had a number of surgeries, a lot of orthodontic work as a teenager. Had a jaw surgery. I had surgery at the age of 1. I had surgery, tonsils removed at the age of 7. Another surgery at 12, and then another surgery at 21. And now I can't lay on my back without my head extending. It causes me to snore. Whenever I yawn, I cramp up in my suprahyoids. I can't open the jaw, and I have trouble sort of swallowing and breathing when I'm meditating unless I'm in a big extended position. And I've got some jaw deviation and
Perfect.
anything else?
Wow, no, that's a lot. That's amazing. Like so many great reasons to assess hyoid and jaw for Kieran. The capital extension tends to inhibit these guys, and jaw can hyperfacilitate, but it can go either way. It's just dysfunctional. And the sleep apnea associated with hyoid and jaw dysfunction, bruxism is one of the top causes of sleep apnea. The surgery, the intubations that he's had, even he had jaw surgery, so he's intubated and it affects his jaw. So he's a really excellent candidate for this. So thanks for volunteering. Let's put you into a relatively neutral cranial axis. Excellent. And I'll have your water. This is yours, right? Okay. Fantastic. So before we start with that, actually, I was going to keep it nearby. Before we start with that, can we watch your jaw movement?
Mhm.
So go ahead and open the jaw. Yeah, it's super interesting. You're very, very, very much like Stu. The deviation doesn't happen out of the gate. Go ahead and open. It happens way worse. He's really on the cusp for me though. When I see that, I'm like, oh my God, it starts to deviate about the level of the jaw level, which is about 2 finger breadths. So I'm just not sure. I want more testing. Kieran, can you put 2 fingers in your jaw? You guys deviate to the same side, you and Stu. That's pretty cool. Easy, okay. And now how about 3? That is not easy. Okay. Not so easy at all. So for Kieran, we may be stuck on hyoid to hyoid also, to be honest, because the 3 finger breaths. So just to let you guys know, like if someone finds this relatively easy, and when they do this, they don't. If the forcibly jaw opening is not going to be jaw. Forcible jaw opening is always going to be located in the suprahyoid region. So we're not sure what we're going to find yet, but if we don't find tonicity and tension in the hyoid, we may have to, hyoid to hyoid relationships, we may have to go into the jaw as well. Okay, cool. So now we can do a swallowing test. So I'm going to put you at your neutral axis. Good. And initiate swallowing. That looks pretty hard out of the gate.
Yeah.
And then it should be easier when the jaw is on the roof of the mouth in a normal person. So, not that you're not normal, a non-dysfunctional person in this region. So let's go ahead and put some water in. And tongue to the roof, initiate swallowing. Like Stu, definitely not easy. You and Stu are buds, man. Clearly buds. Let's actually just palpate the hyoid now. Let's see which way you don't move. There's not a lot of movement side to side at all. I felt a lot of trouble being able to get the hyoid to initiate swallowing. You guys saw that too. Whether it was tongue on the roof or not. This hyoid feels very stuck. Okay. And so let's just bring your jaw out. And unlike Stu, you have a lot of tension on the left mylohyoid. Posterior part of mylohyoid at the mylohyoid line. Also a lot of tension. So both of these are pretty tense. Would you agree with me, Kieran? Anterior belly not nearly as high tone as mylohyoid. What about your geniohyoid? Put the tongue on the roof. Try to open the jaw for me just a little bit. I think I'm feeling mylohyoid still. Okay, great. And then, have you had any shoulder dysfunctions on either side?
Yeah, a little bit of left
A little bit left.
stuff, nothing major though.
Well, I don't feel a lot of tone on the superior belly lumbal hyoid. So like Stu, he had a lot of tone, which is why I checked his shoulder. Hyoid problems cause a lot of shoulder dysfunctions through the superior and inferior belly lumbal hyoid. Oof. A lot of tension on sternohyoid here. Woo! And you feel, I don't think I can even get my finger in there. See the dent here? And then I can't get my hand in there. I want you to feel that, Kieran. There's a lot of tension. Okay. Do you have tension upon swallowing down here? Take a sip. See if you feel it. I bring someone's awareness and say, do you feel a difference side to side?
A little bit.
Okay.
A little bit.
If I don't find anything here, he's a pretty good candidate like Stu for hyoid to hyoid relationships, but if I don't find anything, the 2 most tonus things I find are the sternohyoid on this side,
Yeah, it's spicy.
the mylohyoid left and the mylohyoid right. But I don't feel any real pressure on your superior belly, lumbar. I'll check the inferior belly. Okay, raise the shoulders up. Okay, put it down. Okay, go ahead and swallow. Those feel pretty normal. Okay. So both these gentlemen, we lucked out, and they both have a jaw deviation to the same side. Some of their muscles are similar. We have mylohyoid, sternohyoid. On Stu, we have mostly right-sided stuff. Okay. So to see if the mylohyoid on this left side is contributing to Kieran's dysfunction, we might want to test these structures against each other in our repair TLDOD. If we don't find anything local to the hyoid, then we can look at hyoid relationships to his jaw. Okay. So, Stu, would you like to go first? Yeah, and then we'll go after Kieran. We'll see which one of you guys might end up both of you being hyoid to hyoid. See, the best of you probably is here. Okay, so let's just do. Because you're so much taller than I am. Okay, I think we got you in the view. Okay. So, Stu, we're just going to do basic perturbation, and then we're going to look straight ahead. Take a deep breath in, all the way out, and then go and push. Okay. Goes into a good amount of back extension. Can you put your hands here? So we're stuck on the x-axis. Deep breath in, all the way out, and then go and push. And that does give us some neurolocks. There may be some hyoid involvement. Okay. All right. So Stu, let's put you. Is that a good view, Stu? What do you think? Is that pretty good? Okay. And maybe we flip this around. Let's see your head the best. Yes. Perfect. I'll try to be a better door than a window, folks. Okay. So the first thing I'm going to do is just passively, now that he's seated, just make sure I can feel my direction of ease on the hyoid. And that is not something I'm going to do at the start, just something as a reset in case there's an involvement. Still that restriction over to the right on Stu. Still does not want to go up on the right side or down on the left. Rotation feels okay. In fact, I just don't feel like a lot of rotation, period, which may be because there's an x-axis problem. Okay, let's just check some muscle that's an intrinsic. For you, I know you have like some multifidus stuff. Okay. So deep breath in, all the way out. Don't let me push your legs out. Okay. And can you put your finger on your hyoid? Deep breath in, all the way out, and then don't let me push. Okay, and we do get a lock, so we know that from intrinsic perturbation, there's likely a hyoid involvement. We know that we've got a multifidus known intrinsic, and he's a back pain sufferer, and it neurolocks with hyoid. We're not going to treat that right now. We're going to look for local relationships that are higher priority. Since the hyoid has a lot of control over our axes of movement, we want to see if there is a hyoid to hyoid relationship. For Stu, we think that there's a pretty priority between his hyoid to hyoid because he has a lot of trouble getting 3 fingers in, right? And there's high tone structures on both sides of the hyoid, both super and infrahyoid. If you're finding that, you may have to stay local to the hyoid before you go into the jaw. If you had the 3 fingers not be able to go in and they have a jaw deviation, jaw dysfunction, and you didn't find any tonicity in the infrahyoid region, then you might be able to go from suprahyoid into jaw. But for a prioritization, if you have something very local to the hyoid, the odds are it'll throw off something else local first as an antagonistic action, super to infrahyoid because he's high tone on both sides, much like Kieran. All right, so let's find our indicator, okay? We'll use something away from his hyoid. Make sure I can see this. I'm just gonna tilt that a little bit. Try not to mess it up. Here we go. Okay, hopefully you guys can see me okay. And so we're just gonna check rec fem, which is normal tone. We want a normal tone structure that's strong and clear. And don't let me push down. Okay, and we're gonna spindocell compress, proximal rec fem, and then retest, and it goes weak pretty easily, which is a great indicator. Can you put your finger on that mylohyoid that was pretty high tone? The highest tone 2 structures for him were the right mylohyoid and the right superior belly homohyoid. Okay, and there's TLing, deep breath in, all the way out, don't let me push. It does not make the indicator go weak, so they're not in a dysfunction together, and we can use the indicator for mylohyoid. Can you put your finger on the superior belly homohyoid, and that's basically just medial to the SCM underneath the greater cornu. So he's gonna put his finger there, deep breath in, all the way out, and then don't let me push. It does not make the indicator go weak, so they are not in dysfunction. Now the rec fem doesn't exist anymore. It is our indicator for these muscles. So whoever we TL is whoever we're testing. Can you stimulate that structure right there? And TL for superior belly homohyoid, we're gonna see if it's dysfunctional. And don't let me push down. And it is very dysfunctional, okay. And now go to the mylohyoid on the right. He's gonna stim and TL that. And we're gonna test that against rec fem, and it's also dysfunctional. So we know that we have two dysfunctional structures, Stu, two of which are high tone, two of which basically discourage movement of your jaw over to the left, leaving the jaw to kind of go to the left if it needs to, and two structures that can pull your thyroid cartilage and hyoid bone over to the right. So we're on the money, I think, with something really good. We can't prove it until we do a pair TL, right? So what we're gonna do is stimulate both and TL1. We're gonna stimulate both and TL1. I'm gonna do that for Stu. 1, 2, 3, 4, 5. He's gonna TL the superior belly homohyoid. You can hit either one. And now don't let me push. And they cancel out each other's dysfunction, which makes them a pair. So I'm not gonna go into Stu's jaw right now, even though I saw the deviation, right? If he has a mylohyoid dysfunction at the end of jaw depression that might be related to his jaw deviation, I might be able to get the jaw to clean up slightly by working on the hyoid, because don't forget the suprahyoid muscles are jaw muscles. So in these people where you see a deviation or a trouble happening after the 2-finger mark, then you may want to really stay local to the hyoid first. And then if you don't find something, then go jaw to hyoid. Okay, awesome. So can we see if they're a pair? I'm excited. Are you excited? I'm super excited. Oh no, we know they're a pair. We know they're a pair. We need to find the direction of dysfunction. Now I'm really excited. Okay, so can you stem the mylohyoid here? And now TL the superior belly. And now don't let me push. Okay, okay. Go right there. You're on the SCM, sweetheart. So right there. Stem that. And TL right there. Right there. Perfect. Make sure they're not on the SCM. And now don't let me push. There we go. Okay, just making sure we have good accuracy. And then stem that superior belly so he's just medial to the SCM. And now TL underneath the mylohyoid. Good. And let me push. Okay, all right. So it looks like our mylohyoid is inhibited and our omohyoid is facilitated. Do you mind doing this seated up by the camera? I normally would do it laying down, but because it's a study group, I want them to be able to see. So if you don't mind sitting for us. I'll just show you a really special of how I release the superior belly. And so Stu gets to do this in front of lots of people. It's a very sexy look, okay? So what you're gonna do is you're gonna tilt your head over to the left. Good. Take your chin up towards the ceiling. Good. Bottom lip over top lip, which is my favorite part. He's gonna gently hum. I'm just gonna gently. It's a very good look for Stu. He didn't know what he was volunteering for. Sorry. Okay, let's go back to neutral, and now let's do the distal part of the superior belly. So now we're going to keep the neck relatively neutral, and you're going to start to rotate into external rotation, and you're going to abduct towards me. Good. And now do a little hum for me. The hum helps to release this superior belly homohyoid. Very good. Okay, can we do one more pass?
Sure.
Okay, because then I know they want to see it again. Let's go into left head tilt, chin to ceiling. Good, bottom lip over top lip. Good, and hum for me. I'm careful not to overstretch the omohyoid. I don't want to traction the suprascapular nerve, so I'm just going to do opposing motions here, giving him some slack at the scapula so he can move the superior belly at the hyoid. And then come back to center. Nice hold, by the way. Wow, that was impressive. And now keep the neck neutral and just start to rotate the humerus out. The shoulder just drops naturally. Abduct. Good. And hum for me. See how much clearer his voice is getting. That will tend to happen when you do hyoid corrections. Fantastic. Really, really good. You okay? Okay. So I can look in to see if his supraspinatus test improves. Deep breath in, short right there, all the way out, and don't let me push. And it does. He feels really solid, I'm sure, on that. And for infraspinatus, deep breath in, all the way out, don't let me push. Those are just global patterns, and if you take the parking brake off the superior belly hyoid, it can tend to not traction the suprascapular nerve and decrease the neurology to supraspinatus and infraspinatus. Very cool. Now we need to stimulate the mylohyoid. All right, so we're going to come underneath here, neck neutral as your neck line. Okay. Come underneath here. We're going to find that sore spot. Am I on it?
Yeah.
Okay, that feels pretty good. And I'm going to cross stem. So since the mylohyoid line is going this way across his mandible, I need to cross stem by doing this action, right? So I'm going to come across over to your left ear, okay? And I'm going to have you just gently drop the jaw and just gently deviate to the right, not a big deviation. The mylohyoid is going to encourage movement towards the same side. So to activate it, I'm going to drop his jaw by forcing it open and deviate over to the right. The whole time I'm keeping his neck very neutral. I don't want him to create cranial compression. I find a lot of C0, C1, C2 compressions from the jaw and from the hyoid region. Is your water? Cool. Keep that close. Okay, so I'm just going to check the tone on those. Great. Can we pop you on the table?
Sure.
And head down this way. Okay, let's see if these guys are still dysfunctional. Okay, so we're going to stim 1, TL1, and see if it's still dysfunctional. Can you put your finger underneath? Great. And stim. Good. TL that same one. Good. Deep breath in, all the way out, and then don't let me push. It's no longer a factor. Good. And now, can I just check your global pattern? Take a deep breath in, all the way out. Don't let me pull your heels up. That seems to clean up. If we throw some dysfunction in, we can stimulate the superior belly hyoid. We should throw some dysfunction in if it's still facilitated. And now don't let me pull up, and it doesn't. Do you mind standing up for us? Good. We'll go into perturbation. We're doing a bunch of challenges just to check ourselves before we wreck ourselves. Okay. Take a deep breath in, all the way out. Oh, sorry. Better. Deep breath in, all the way out, don't let me push. And we can't seem to screw them up, which is great. We'll stimulate superior belly, deep breath in, all the way out, don't let me push. Still can't mess them up. So let's come over to the camera again, Stu. Grab your water. And now, let's do our swallowing test and see if there's any improvement. So I'm going to feel for the movement. Seems relatively relaxed. Can you take some more water? This time he's going to have the tongue on the roof, neck is neutral. And easy peasy lemon squeezy. Look to the screen, awesome stuff. And then go ahead and open the jaw. You can see very minimal deviation, which is super awesome. Can you put 2 fingers in between your jaw again? This is the jaw, and now put 3. You can see 3 fits, nice. Now you can eat that big burger, right? Big Australian barramundi burger, right? Okay, so just check the tone, all feels pretty good. And if we wanted, if you still needed to do the passive hyoid release, I don't think Stu actually needs that now. I'm gonna feel here, I feel very good, ease to the right. But you could also do a hyoid reset after that correction. And as David says, push into the direction of ease, which would have been Stu's left side. I would never have pushed into his right when I felt a right block. But Stu's muscle-to-muscle corrections actually corrected it. So I don't think that we need to. But if I needed to, I would do it. And this is the time I would do it, like right towards the end, just to make sure that he leaves with a really good central position. Good. So your homework is to release your superior belly hyoid with that funky hum, bottom lip over top of thing.
Yep. Yep.
And then to immediately follow that by activating what's inhibited, which is the mylohyoid. You can do your swallowing test as a self-assessment throughout the day. If things are starting to tighten up, that swallowing test is going to be hard again. Or putting 3 fingers in your mouth is going to be hard again. So you can do those as self-assesses, which is really nice, rather than an arbitrary number and do it twice a day. You can actually do it as many times as you need. And if you've been assigned KT homework on intrinsics, I know you're assigned modified Superman and things like that, you can do this right before you do that and it might be more successful.
Great.
Cool?
Thank you.
Thanks a lot. Get the heck out of here, man. Last but not least, the amazing Kieran. We'll bring him back. Remember, Kieran had a very tight left and right mylohyoid and sternohyoid. Also has quite a bit of jaw dysfunction. So if we don't find any pairings for Kieran in this hyoid region, then we can maybe go to things that we do feel are tight and high tone, possibly dysfunctional in the jaw. So I don't know what we're going to find. I'm pretty excited. Okay, so let's take a look. Let's put Kieran into a perturbation. So let's stand him up. And Kieran, have you been working on anything in particular I should know about as far as intrinsics or?
Yep, just scars from the surgeries, mainly the abdominal one,
Yeah.
hip scar,
Okay.
and then wisdom teeth scars helped and stuff, and also
Sweet. So the jaw dysfunctions could sometimes be from the scarring from.
yeah, it's cleared up the stuff a lot with wisdom teeth scars.
Okay, cool.
And the chair.
Yeah. So he's done a lot of jaw-to-jaw corrections already, but again, Kieran, you're so tall. I don't know if you're in the camera. There we go. So let's see where you're at. Take a deep breath in, all the way out for A to B perturbation. Don't push. Okay, so we got a bilateral toe flare. And can you put your finger on that high tone spot in the hyoid right there? Good. Yeah, that's good. Deep breath in, all the way out. Don't push. Okay, that gives us a somewhat lock. Let's actually go underneath. There you go. It's underneath in the mylohyoid groove. And then don't push. That's a little better. Now you got a left mylohyoid. Can you go to the left mylohyoid here? Good. Deep breath in, all the way out. Don't push. And a little bit better, but not so great. And then let's go to sternohyoid here on the right. Let's go down to the manubrium. She's got a therapy localized to the manubrium. Deep breath in, all the way out, and then don't push. Ooh, a pretty big block on that one. Holy moly. So because all those seem to turn on A to B perturbation, we're going to stay local to the hyoid right now. Okay? Let's bring this close. We've got so many intubations, and intubation is such a huge indicator for hyoid. Let's see how that goes. Can you put your head down this way here? So because both toes flared, I'm going to check my tip is. Make sure that you're in the camera here. Take a deep breath in, all the way out, and then do a push up. Okay. And you said when you do core work and stuff, you tend to go into cranial extension? Okay. Okay, we can see that. It seems to be something secondary for you. Can you put your hand on the hyoid? Because therapy localize the hyoid. Okay. Deep breath in, all the way out, and then I can already feel this is going to lock. He really locks down. You notice no cranial extension. Sometimes when you see a lot of cranial extension, it's a secondary, tertiary compensator for not being able to access the intrinsic, so people will go into that cranial jut. That can really perpetuate hyoid dysfunction because it causes sleep apnea, bruxism, and even jaw dysfunction, as a secondary. Okay, cool. So let's actually see if you have a hyoid to hyoid. We need to go into the jaw. Okay. So let's see if you have an indicator available. Can I check your rec fem also? Do you have any dysfunctions here I should know about? You said you guys have hip stuff.
Surgery on this side.
Ooh, okay, maybe not. Try this one.
This side, no problem.
This one's okay? Okay. Check this one. I'm just going to go away from the side that I'm testing. Take a deep breath in, all the way out. Don't push. Good. Deep breath in, all the way out. Don't push. He goes very weak on spinal cell compression and goes into these compensations again, so I think that I can use rec fem. Everything feel okay? No pain? Okay, good. So I'm going to have you just TL. He's going to TL the mylohyoid, much like Stu. Okay.
This jaw portion?
The mylohyoid, yeah, there you go. So he's right underneath the jaw here. Good. And deep breath in for TL, all the way out, and then don't push. Not any dysfunction with rec fem. Stay there and just stim and TL it. Let's see if it's dysfunctional. And deep breath in, all the way out, and don't push. Yeah, it's very dysfunctional. Okay. So far we know the mylohyoid is dysfunctional. If for some reason we don't get any kind of dysfunction with these guys in a pair, then we'll go into jaw. But right now I'm staying local. So let's find the sternohyoid right here. Oh, I'm sorry. Okay. Very tender here. So we're just going to TL it to see if it is in a dysfunctional relationship with the indicator. Deep breath in, all the way out, don't push. It is not. Stim and TL. Good. Deep breath in, all the way out, don't push. Looks like we're, so far, going to see if these two are in a dysfunctional relationship. Now, hold on. We have this tertiary left side mylohyoid. Can you put your finger there? Let's just TL it. Deep breath in, all the way out, don't push. Good. Stim and TL. Deep breath in, all the way out, abdomen push. And it is also dysfunctional. So we're going to stick with the two that are the highest tone first, that have a highly antagonistic relationship together, and we'll see what we find. So let's stim them both. Let me do that for you, Kieran. So I'm stimulating the mylohyoid and sternohyoid at their highest tone spots. And Kieran, can you TL the sternohyoid? Deep breath in, all the way out, abdomen push. And it does give me a lock. Just to double check, I'm going to check the mylohyoid to mylohyoid. And we'll stimulate this, both mylohyoid, and can you TL that for me? Good. Deep breath in, all the way out, and then abdomen push. Not our dysfunctional relationship between the mylohyoid. Mylohyoid doesn't make our indicator lock. We'll double check mylohyoid to sternohyoid, left side mylohyoid, right side sternohyoid. Can you TL that for me? Deep breath in, all the way out, and then abdomen push. And I think that we're stuck on that first one. Right side for both of you guys. It's not so weird, they deviate the jaw on the same side. They have a very, very similar pattern. So neither one of these guys so far looks to be jaw to the hyoid, unless we don't get these guys to cancel each other out completely. Let's just double check. And I think we're gonna find these to be our big pair. Deep breath in, all the way out, abdomen push, and they are. So we're gonna stay local. So you have to do this before you would go into a relationship with the jaw for these guys. Nothing dominates the central axis of stability like threatening someone's breathing. So despite the fact he's done a lot of jaw surgeries and he's done a lot of scar work, he's got a local hyoid issue. Let's find that. Just gonna find the highest two-tone spots, okay? So I'm gonna stimulate this one and TL this one. So he's going to stim the mylohyoid and TL sternohyoid. Deep breath in, all the way out, and abdomen push. We get a lock on sternohyoid. Can you stimulate the sternohyoid? And then TL the mylohyoid. Deep breath in, all the way out, and abdomen push. Okay. Ooh, wow. Mylohyoid's pretty inhibited on the right side. So do you mind doing this on the camera? Another weird one. Are you ready to get a little weird? Now it's not Australia, now it's New Zealand. All right, so let's get you down on the ground on your butt. Kieran's from New Zealand, so we're representing multiple countries here today. And so let's get you to where you can see you in the camera. Good. You okay? So I'm going to teach you all about the sternohyoid here, central axis neck. Can you put your finger here for us? Good. And what you're going to do is you're going to bring the chin towards the ceiling. Good. Bottom lip over top lip. Good. Tilt a little bit to the left and hum for us. Just making sure he's not swinging the head back and it's just elongating this pretracheal fascia. Good. Inhale and come back. Good job. Again, I'm just pulling up on his cranium. How's the tone going on your right hand? Starting to drop?
Yep.
And that last one was really good.
Feeling the pull.
The pull?
Fashion.
Let's just double check the tension here. Starting to sweat a little bit too. Let's do one more pass, okay? I'm going to check the cranial axis so he doesn't go into hyperextension. Just doing a gentle hum just to release the tension on sternohyoid. I can see you can go pretty far with that. Okay, wonderful. And just like Stu, we're going to stimulate the mylohyoid here. So keep your fingers under here for me, Kieran. Good, right there. Perfect. And you're going to stimulate this way, okay? And open the jaw. Good. We'll do a slight right deviation. Good. You feel it start to give. Okay, cool. Great. And so now let's put you back on the table. We'll check our indicator. tone. We'll just stem 1, TL1. Keep your finger on that monohyoid for us. Deep breath in, all the way out, don't push. Okay, looks like it stays strong. Arms to the side for us, Kieran. Deep breath in, all the way out, don't push out. Everything's good with multifidus too. This is looking good. All right, let's stand you up. We'll re-perturb you. Just making sure our global power to the side. Straight ahead. Deep breath in, all the way out, don't push. Good. We try to mess it up. Deep breath in, all the way out, don't push. And even putting dysfunction in the system doesn't seem to do it. Great. So we can also do a hyoid reset if we feel that the palpation of the hyoid is not set. You may not need to. We'll take a look. A little bit of resistance to the right. So I'm just going to do a push to the left in the direction of ease. I'm never going to push into a direction of tension on the hyoid. No direct hyoid releases. Just gently pushing the hyoid over to the left. You okay?
Just feels like the multifid.
Yeah. People often start to feel their intrinsic core start to come on. Okay, I think that should do it. Okay, let's do a swallowing test, shall we? So, we'll put some water in. I'm going to feel his hyoid. Don't swallow just yet. Centralize cranial axis. And go ahead and swallow. And that looked like a cinch. And then let's do one more. Right? And big drink. Neck bone chin tuck. Tongue to the roof. And here we go. Great. And now face the camera still. And let's watch your jaw. Quite open. That's a lot of width and not a lot of cranial extension. So this is a pretty big one for him. So if you go chasing jaw when someone has a hyoid problem, it might not fix the jaw problem. And so we just want to elucidate that to you. Now, if for some reason his jaw deviation started to come out to one side like really loud, or he couldn't open in those first couple of inches of his finger test, then I would start to go after jaw relationships to jaw or jaw relationships to the suprahyoid region, but not a good candidate. Can you put 2 fingers in? Good. And put 3 fingers in. Still a little struggle with the 3 fingers, so now might be the opportunity for me to start looking at suprahyoid muscles in relationship to all the elevators of your jaw. Now I have the clearance to do that. I didn't have the clearance before. So this is a good opportunity for, on the next visit, I'm going to say, Kieran, after you do your homework on the hyoid, now we're going to go to elevators and how they may be inhibiting the things that depress you. Okay? Hopefully you guys found this helpful. Okay? I'll write this up for you guys and send you all the notes on both these case studies, as well as just including the functional tests. Functional tests are optional, but they just may guide you to where you want to go next, which is the whole point of NKT, is getting after the primaries and not chasing around things that are trickle-down effect. Thank you so much for volunteering. Stu, wherever you are, thank you, and we'll see you next time.